So now we're going to go into the what I call general radiation questions that we get inundated with, and it's important to address those the rest of the way. So my favorite one is if someone gets surgery, right? They are told the best PSA is an undetectable PSA after surgery, right? Just flat out. I mean, of course, not zero, but they use ultrasensitive tests. So now if I threw that question back at someone who has such a history of radiation therapy and treatment to you, and someone's coming to you and they've been treated or they're about to be treated, what are we looking for in terms of a PSA response? Do you expect your patients to go extremely low, to go to zero after 6 months? I mean, what's the expectation when it comes to specifically PSA and radiation?
Well, it's a whole lot easier to do surgery and then follow the PSA, and if it stays low, you're good.
Right.
It's not the way it is with radiation therapy. With radiation therapy, we don't kill all the prostate or remove all the prostate tissue, so it continues to make PSA. And there are many different patterns, in part depending on the kind of cancer you have, the biology of that cancer, the kind of radiation that you received, and so forth. As I showed in one of the slides, at least 50% of the patients who have HDR monotherapy will drop down significantly their PSA from, say, 8 down to 2 or 1, and then it might hover there for a while. And within the first 5 years, it's not uncommon that it goes back up to 1 degree or another, sometimes rather dramatically. And I spend a fair amount of my time explaining to patients that it doesn't mean failure. And given our track record, the vast majority of patients, those rises will represent a bounce. But it is a trying time for patients and doctors alike when you have to start interpreting. What you don't want to do is go in too fast and go in and biopsy or make the assumption that the patient has recurrent disease when in all likelihood they don't. If you're starting with a patient with high risk disease, starting out with a PSA of 50, T3, and so on and so forth, and they come back a year later and their PSA is rising, you better start worrying. If they had an intermediate risk group and you had a PSA that started rising, in all likelihood, that's a bounce. So it's a challenge. There's no easy answer. Things like PSMA scans are becoming helpful in making those kinds of determinations in patients who have no prostate, residual prostate. You can use a very low number like 0.2 and do your PSMA scan, but when you have an intact prostate, there's going to be some background, so the number has to be higher, more like 2, in order to do your PSMA test to evaluate for evidence of recurrence.
So is it fair to say that if you still have a prostate, this being the symbol of a prostate in my house, if you still have a prostate,
yes.
I know, but as we get older, the prostate, God plays a horrible joke. Our prostates get bigger, right?
Yeah,
our brains shrink, but our prostates get bigger. So if you have a prostate still in there and you're getting radiation, is it safe to say that everybody has their own individual low number in terms of a PSA response, and you're just kind of monitoring a range to see if you're comfortable with the treatment outcome, right? So people shouldn't have the expectation to go to 0.1 or 0.09. You're going down to a lower number, and you're staying at that number and a range of that number years and years later, correct?
Yeah, originally when I started doing this, one of the criteria was you had to be 0.2 or less after your radiation therapy. And I don't think that's a valid conclusion at this point. I like to see patients go less than 1, makes me feel comfortable. And if they stay in the 1, 1.5, half range, I'm feeling pretty good about them. But remember, within 5 years, half the guys are going to be going up. And it takes, in fact, in one study we did 2.5 years for the PSA to even nadir. So it's going to go down, and it can bounce more than once, and it can go up and down. You have to work closely with your experienced brachytherapy radiation physician and your urologist to make sure there's a coordination going on there, so we're not treating the patient unnecessarily or doing biopsies that maybe might be not needed or potentially harmful.
Did you say 2.5 years? You said 2.5 years to go to that point?
To the final nadir.
Wow.
Not to be surprised, it can be a long time. Now, typically, the PSAs drop by about 50% within 3 months, but not all the time. And if they don't, I don't get too worried about it. I can't recall one where it went up above the baseline, but when we check PSAs just before we do treatment, but even that, I wouldn't get too excited about. I would just repeat the PSA in a few months.
But these bounces that you discussed, the bounce, is it an undulation? Is it a series of bounces, or is it generally are you saying bounce singular that some people can expect after radiation that doesn't necessarily mean it's cancer coming back, it's just an effect of inflammation or something else there?
It's both. I don't understand the mechanism completely. There are patients who bounce just once, and there are patients who bounce multiple times.
Wow.
Yeah. So you have to, and again, the typical bounce is in the 1 to 2, 3 range. I have had patients at 10. I had one guy at 16 and didn't treat them. They didn't want to go with treatment and waited, and their PSAs went away.
And how does, okay, so I don't know if there's anything else to cover on the PSA.
Well, let me interject that PSA rises after 5 years are considerably more worrisome for recurrent disease than when it happens in the first 5 years.
Okay.
I know very well that 10 years is, not even necessarily 100% safe territory.